Hi, everyone. Welcome to the audio and video podcast of the Cleft Palate Craniofacial Journal. I'm Pat Chibbaro here in New York. I'm a pediatric nurse practitioner. And this paper that I'm going to be talking with two of the authors about is about speech. And so one thing I asked them was to talk to us like we are not speech pathologists, that we are members of the team that really will benefit from hearing about this kind of work, because I think all of us need to know a little bit about what everybody else on the team is working on and is doing. And I've always learned over the years from my speech people. Shout out to all the speech pathologists and the ACPA. So this article, which just came out OnlineFirst, December 2nd, so it won't be hard for you to find, is examining factors that impact speech acceptability and intelligibility in 4 to 7-year-old children with cleft palate. And the authors are Jessica Chee-Williams, Julie Liss, Kelly Nett Cordero, and Nancy Scherer. And they are all from Phoenix, Arizona, which I wish I was at now since it's about 15 degrees here in New York. And they are from the Program of Speech and Hearing Science, College of Health Solutions, Arizona State in Tempe, and Phoenix Children's Center for Cleft and Craniofacial Care, Phoenix Children's Hospital. So I want to welcome two of the authors, Jessica Chee-Williams and Kelly Cordero. Thanks, ladies, for joining me.
Thank you for having us.
So let me first start by asking you both to just tell us, and I always ask this question, I'm always interested to know because we know doing research takes work, and it's definitely a team effort. What motivated your team to do this work or to pursue this study?
Yeah, I think one of the things that we on our team, right, there's this cyclical relationship between research informing your clinical care and your clinical care informing your research questions. And something Kelly and I have talked a lot about over the years is when a child comes for a cleft tube evaluation, we are, as a speech pathologist on the team, we're assessing several different parameters, their hypernasality status, their articulation, and these other factors. And there's this idea of a composite measure that captures kind of their global speech. And two of the measures that are available to us, which I will tell you what they are and then toss it over to Kelly for her to kind of explain further, is this rating of speech acceptability and this other measure of speech intelligibility, which are two different things. And we wanted to kind of dig further into what are we doing as speech language pathologists that inform these ratings, and also for us to further discuss, are one of these ratings more appropriate for research? Are some more appropriate for clinical care? Both. And the spoilers, we don't super have an answer for that today, but this was part of us exploring that a little bit further. So maybe Kelly could explain more about acceptability versus intelligibility.
Great, thanks.
And so, yes, for those who haven't heard those terms much yet, I'll start with speech intelligibility, which is also sometimes called speech understandability. So it's how much a person's speech can be understood by those in their environment, those they interact with, their family, their peers at school, and anyone they come across. So really, truly, is the message being understood by the listeners? And then speech acceptability. Speech might be understandable, so they might have intelligible speech, but it might not be, quote, acceptable, which there are some feelings about that word as well, but it's been used in the literature to explain the phenomenon of sounding different from your peers. Even though you're understandable, your speech might be different. We face that a lot with our patients that have clefts because they might have residual degrees of nasality or hypernasality, that even though their speech it can be 100% intelligible or understandable, it might not feel acceptable to them based on sounding different from peers due to having nasal airflow or hypernasality when they're in their speech still after their surgery.
So that the acceptability then it will impact how they're, how things are going for them in school. Are they being teased about it? What is it sort of, what's their quality of life based on the level of their speech? So So then let's talk about this study then, and maybe you can walk us through what was your hypothesis, what were you thinking, and what did you actually find? If you want to both, jump in, or whoever wants to go first. I know you both can answer
I'll let
this.
Jessica take a start there. I'll jump in as needed.
Okay, great.
So we had these 30 children all do the same speech sample, and we had a lot of demographic information on them. And what we were interested in terms of, we wanted to see what kind of things were related to intelligibility, to acceptability, and if there was any overlap. Now, in the literature, when we look at what are the factors that impact intelligibility, for children without a cleft, age is the biggest predictor of intelligibility, because we know that kids' speech naturally develops and gets more intelligible with time. And so we had hypothesized that we would find something similar in our study, that age would be a factor related to intelligibility, and similar with the literature, and also consonant accuracy. And we were hopeful that the factors that impacted speech acceptability we hypothesized it would probably be related to both hypernasality and their consonant accuracy, because that's kind of the definition. It falls in line with the definitions of acceptability when you read through how you rate it. So that is what we hypothesized. And we also wanted to see, are there roles for like the child's gender? Is there a difference between boys and girls and their age, and these things that are kind of more related to the child? And I think one of the most interesting findings, and I'll be curious what Kelly thinks, is that for our little sample size, age was not a predictor for either thing. And so while that may be true for other children or in other areas of speech, that wasn't the case in our study, which was a very interesting finding.
So why do you think that? When you look into it deeper, why do you think that is?
Well, I mean, I would say that it's sort of what I'm going to allude to here gets to that question a little bit. Another thing that we looked at in this study was the presence of what we call like cleft related speech errors. So there are errors, like, as we know, kids, like Jessica talked about, kids have developmental speech errors when they're young that resolve as they age. When we call an error cleft related, there's many names for them, but when we call them a cleft related speech error, they're very different than those. They're produced in the nose and the throat, and they can make speech harder we feel harder to understand, so less intelligible. And I think one surprising thing there was that those were not as directly related to the one of the intelligibility measures, if I'm saying that correctly, Jessica. And they were definitely related to hypernasality. But I think what was really surprising to me was how much the percent consonant correct, like meaning just their overall consonant accuracy, had to do with both the intelligibility and acceptability measures.
So I have a lot of other questions. As I'm thinking, listening to you, I have a 2-year-old grandson now, and I'm just thinking about the evolution of his speech. And every time, it's so interesting because every time I go to visit them, I understand things that I didn't understand the last time. And, it's just so interesting. I just keep thinking about the whole development. It's just so interesting to me. And then, layering on top of that, if he happened to have had a cleft, what would those differences be? So interesting. But that was just a little aside. I was just thinking my little grandson Luca, who's just coming along so nicely with his speech, because of course I'm always worried, that is it delayed, and I'm calling all my speech friends. And so you guys are amazing, by the way. Shout out to all the SLPs. That being said, let's get back to the paper. So but talk about what you did, because, what the study was, because one of the things I thought was interesting, and as I was reading it, I was thinking about how how you evaluated the kids, and you had a camera and you videotaped them. And one of the things that you talked about later in the paper was about the need for this to be done more consistently, that this type of assessment, specific type of assessment, maybe you can articulate what that was. And my thinking was, do speech pathologists on teams around the country have the ability to do this consistently? Like, is it, are some teams more well equipped to have the speech pathologist do this more consistently? Do you know what I'm getting at?
Pat, you're asking all the hard questions that we talk to all the time with our colleagues. You're exactly right.
Yay!
Got it.
Yay.
I think that one thing that speech language pathologists are very familiar with is this decision-making tree. I believe originally drafted by Judy Trost-Cardamone. Kelly, am I correct? And so we think about this decision-making tree drafted. And when a child presents to the cleft team, many of us are very familiar that it is our role to say, does this child need speech therapy? Yes or no? Does this child need BPI surgery? Yes or no? Does this child need nothing? Right? Because there are cases of that. And there was another paper that was just published last month that kind of talks about what some of the teams are doing. And so one of the things, and I'll let Kelly talk about more too, like her experience with AmeriCleft and helping to shape our protocol, but we want to answer both of those questions when kids come to clinic. Do they need surgery? Do they need therapy? And so we have built a protocol to answer both of those questions. But this paper that I'm referencing that just came out last month, also in CPCJ, found that only half of teams are assessing articulation when they come to the cleft team. So they're either leaving it to the school therapist, a community therapist, or asking them to come back. And I think our paper highlights how critical it is that we are assessing consonant accuracy, both so we can recommend speech therapy, but also because that was the common factor that impacted both intelligibility and understandability. So maybe Kelly could talk a little bit more about where we landed on our protocol to make sure we could fit in both of those pieces.
Actually, when you were asking that question, Pat, I was thinking, I really love that someone who's not a speech pathologist or a surgeon asked that question, because that is one of Jessica and I's very favorite topics, is the use of like a standardized protocol in the cleft clinic setting. It's something we've worked on together for almost 10 years now here at Phoenix Children's. And it is based on the work of AmeriCleft and also with foundations from tests that were utilized from the very well-developed audit system in the UK and now are being used in other multi-site studies and have been used in other multi-site studies such as BPI-OPS and CORNET, which are multi-site studies looking at speech outcomes that are being conducted in the United States or have recently finished. But we feel that it is important to be able to have first of all, archived samples so that you can efficiently look at all of these parameters of speech, of both the looking at both resonance and speech articulation. We do that through the use of a standardized assessment tool, which actually isn't discussed in this paper, but like a standardized one word, like a very common articulation test. But we also use a set of phrases that we score the articulation on, which is how you can determine the percent consonant correct from this study, as well as be able to complete the perceptual ratings of like hypernasality, nasal emission, the things that are important in the BPI decision-making. So you're able to make decision-making regarding both the surgical and the therapeutic aspects of care. And it was exciting to see that really how much the articulation piece is playing a factor, and how much we really should be trying to look at that very accurately at each of our visits. And as far as your question about whether that is accessible across all teams, I mean, it really depends. Like every team has a different model and how much time that a provider is given. But like we do try to work with providers over the years, the speech providers, about having enough time to be able to do, like, there's different sets of this. Like we do complete full evaluations. So we use about 45 minutes with the patient. That's how our clinic is scheduled. So they don't return. They get everything that day unless they need imaging. And we're able to gather all of these parameters during that visit. But there are like some key components that people can do in a much shorter visits and that are being done at many of the clinics.
So I was just looking at my notes when I was reading the paper, and under your descriptive data, under speech acceptability, it says 12 children. So you had 30 kids, right, that you studied? So 12 children, or 40%, were rated as having acceptable speech. 9 of the kids, 30%, mildly unacceptable. 6 as moderately unacceptable, and 3 with very unacceptable speech. So then I wrote a little note to myself up on the top here. Did those SLPs have training or a course in cleft lip and palate speech therapy? So the thing, before we started, I was talking to Jessica about this, that just remember, because the speech pathologist that I worked with for many years, Shelley Cohen, shout out to Shelley, and also Meg Lico, who I worked with afterwards, shout out to Meg, was where they would tell me that, that speech language, cleft lip and palate speech therapy is a course that isn't mandatory. Is that still correct? And I think about that because not every team speech pathologist is able to do the speech therapy, actually perform, administer the therapy, and they have to refer. And so what's the state of referrals? Who are these speech pathologists around the country? Do they have the kind of training that is needed to help, get more successful data, than you're getting? I just was, and again, as not a speech pathologist, that's just one of the things that always sticks in my mind, is that, you talk about different protocols that you all are using, but then I think even, taking a step back to what's the training to begin with. So, and I just was thinking about that, and I wonder what your thoughts were.
And yeah, so I don't know, Pat, you might as well be a speech pathologist with the amount of good questions you
Well,
have here. Our favorite thing to talk about.
After 34 years on a
Yes.
team, I feel like I did learn a little bit, not so much, but a little
Yeah.
bit to understand the challenges that you face as the speech pathologist on the team. So I think about that. I also think about your position is so important to the families, because you are very important to the assessment about whether or not kids need surgery. That is so huge,
Yeah.
so.
Well, and getting to your, they were very good questions, because so the American Speech Language and Hearing Association that has standards for curriculum for teaching speech pathologists, there you do not have to have a full course on cleft and craniofacial conditions. You do have to have a certain amount of content covered, but every
Okay.
university program decides to do that. Like, there's a variety of ways they can demonstrate that they're doing that. So there definitely has been like a struggle with programs, depending on who the faculty are and what the rules are for each, what the decisions are for each program, like how much emphasis is placed on this population. So it definitely is possible to have only had this topic addressed like in the minimum way it needs to meet the hours, like that you need to talk about it for ASHA, which would not be the way many of us received like a full course on this, or had, a practicum placement that was focused on cleft and craniofacial conditions. So that definitely is a concern, I know, by folks that are in academics, is the ongoing need to retain and maintain like cleft curriculum. And in regards to the training, I think there's a few things in your original question about the ratings. So there's a difference also in rating online, like us rating something during our clinic assessment. And then whereas the studies that we've done related to this data, and that Jessica's done related to other data from our center, like have involved going back to re-rate, which, so that we know that we're not having bias based on our familiarity with the patient, because we're not re-rating also typically our own patients in that. I mean, or if we are, we're explaining what's happening in that. But it's very different to go back and re-rate a video versus when you are in the room and you have all the other information going on from the whole assessment to be able to make decisions. So like, I think that helps with the clarity of the data. And that would be considered one of the best practices for reporting on speech type data and these types of papers. And then obviously having had raters who've been trained. So like those of us who've been involved, which is a fairly large number of SLPs that have been involved in any of those studies we mentioned earlier, like AmeriClef, BPI-OPS, CoreNet, and those who've attended the multitude of trainings that have been offered at the American Cleft Palate and Craniofacial Association meeting or other standalone meetings, have been trained like on those scale points. And we try hard to work with each other, or we work within our own clinics to retain our calibration on those.
Right.
Those of us who work in big centers that have multiple clinicians, I know of many clinics that are doing those kind of calibration activities, so that we make sure we're staying consistent with our ratings.
So when you look now at, looking back on your paper, just talk maybe for a minute about, your limitations and your conclusions, and maybe about what's your future, the future directions for your work.
Yeah, I think one of the more interesting conversations we've been having is also who should be doing these measures, because as Kelly said, the reporting of speech acceptability is done by the speech language pathologist. But one unique thing I think about our study, and that a lot of people are moving towards, is having the primary caregiver, the parent, report the speech intelligibility. Because when you're a speech pathologist and you listen to speech, you get so used to kids' patterns. And so I often feel I can understand kids maybe more than other people, but parents are who have the context of a teacher, a stranger themselves. So that was nice to have that parent reported measure, but I think there is still this question: how should we really be assessing intelligibility? And one of the things that we talk about in the paper is, again, this was research, but we really care about the clinical care. We want to know if in a future direction, what do people with cleft conditions and their families want to talk about at their cleft team visits? Do they want to talk about the acceptability ratings, or do they want to talk about the intelligibility ratings? And that's something we don't have an answer to. That is definitely a future direction, because that's something we've kind of talked about back and forth over the years in our clinic. And I also think that one of the other interesting things that we found was, right, just to summarize our quick findings, what impacted speech acceptability was hypernasality and consonant accuracy, but what impacted intelligibility was consonant accuracy. But there was this really complex relationship that we couldn't quite understand, where when kids were hypernasal, they used some more of those cleft speech errors, like in their throat and nose, and that lowered their consonant accuracy. So it just kind of felt like this downstream effect. And hopefully out of some of these bigger multi-site studies coming out, we can answer that in a better way, because we'll have more patients and we can do different types of analysis. So that's kind of where my brain is at right now, both future research and then also the clinical implementation with families and people with cleft.
Great. Kelly, any other thoughts before I reintroduce your paper and hopefully get many, many more people to look at it, including non-speech pathologists, by the way?
No, I don't. I think that was well summarized. Other than I'd say that it reinforced me the importance of the speech therapy aspect, and that correcting the articulation errors is very important, because it showed in this small study, it really showed a large impact on all the factors we talked about related to intelligibility and acceptability.
Well, I learned a lot, as I always do, and thank you so much for helping me understand it even better. So let me reintroduce this paper. Everyone should take a look at this for sure. It just came out OnlineFirst, December 2nd, examining factors that impact speech acceptability and intelligibility in 4 to 7-year-old children with cleft palate. Authors are Jessica Chee-Williams, Julie Liss, Kelly Nett Cordero, and Nancy Scherer, from the place I wish I was right now in Phoenix, Arizona. I am so grateful to Jessica and Kelly for taking time from your crazy busy schedule to talk about your paper. I really appreciate your work and have over all these years. I think you're both amazing. And thanks to everyone for listening. Definitely check out this paper. And to all, happy holidays. Thanks so much. Thank you, Jessica and Kelly, for being with me.
Thanks for having us, Pat. We appreciate it.